على السيستميك diseases. السبب يلي عم نعطي هيدي لأن الأورثوبيدكس مش كلها جراحة، الأورثوبيدكس مش كلها كسورات، الأورثوبيدكس في a good portion of it are diseases. وبيجيكم cases بالكلينيك غير الفراكشرز غير التروما. بقى this is very important. أول topic اللي رح بحكي عنها هي osteopetrosis. Albert Schomburg's disease. osteopetrosis أنا شايف منها كتير cases بالكلينيك تبعي. And you have to keep this osteopetrosis. انتبهوا. It is a rare disorder characterized by a failure of osteoclast resorption with resultant dense bone. And what we mean by no medullary cavity means that we have no red blood cells and they have considerable anemia. And being that this bone is not remodeled and is a solid piece of bone like an iron or like a solid piece of wood, these patients are prone to fractures. There are two forms of this condition. في عندكم الautosomal recessive which occurs in children, of course, وعندك الautosomal dominant. The dominant cannot be is not detected إلا بعدين. If you detect it early, it can be treated. ما بيغير غير. The etiology. The patients who are autosomal recessive, which is the malignant form, these children die at an early age. لأن ما عندهم defense mechanism, ما عندهم red blood cells, the bone is one solid piece, and they die at a very early age. Autosomal dominant. And when osteopetrosis occurs with renal tubular acidosis and cerebral calcification, there is an associated carbonic anhydrase 2 deficiency. All of these questions come to you in the written exam. You have to know what is the problem, what is osteopetrosis associated with carbonic anhydrase 2 deficiency. Deactivating mutations in 3 genes have been found, and inability to cause acidification in the clear zone. The sites of the defects, okay, thank you. Cranial nerve palsy, hearing loss. You see the 3 ossicles, they are solid, they don't move, and as a result, they lose hearing. Radiographic appearance is with symmetric increase in bone mass. تشعل bone mass كلها شافية. A thickened cortical and trabecular, often alternating sclerotic and loosened bands, and بتلاقوا في a reversed Erlenmeyer flask deformity. Erlenmeyer flask هيدي بنستعملها بالchemistry. Let us see. You see إذا بتقشعوا الميتافيسيس عريضة ومن تحت it becomes thin. هيدي بنسميها early Mayer flask deformity. وين الميدولاري cavity هون؟ بح ما في medullary cavity. It's gone. For this reason, they have considerable anemia, poor defense mechanisms, etc. And therefore, these children who have the recessive form die at a younger age. They have, إذا بتطلعوا بالفيما بتطلعوا في transverse bands هون ما بعرف إذا عم تقشع البوينتر تبعي transverse bands تحت التروكانتا. This is typical finding. They have anemia, they have hearing loss, and the cause is carbonic anhydrase 2 deficiency. And in the vertebra, مثل ما بتلاقوا bamboo spine, مثل ما بتلاقوا rugged jersey spine, these patients have the sandwich spine, sandwich vertebra. إذا سألوكم شو هي الفرتبرا يلي تجي بأوستيوبتروسيس بتسميها sandwich sclerosis at both end plates and the clear zone in between. This is the tibia, the femur. طلعوا الارلي ماير فلاس ديفورميتي بتقشع الميتافيسيس عريضه وتحت ترفع. هيدي الفلاسك يلي بنستعملها بالكيمستري. طلعوا بالريبس. You see that the ribs are totally solid. What about the pathology? شو الباثولوجي؟ شو يلي ما عم بيشتغل؟ remodeling ما عم تشتغل. resorption of bone ما عم تشتغل. عندك bone formation, no resorption. شو يلي resorbs bone? الosteoclast. If you look at the osteoclast in these patients, they have lost the ruffled border, the pseudopods. هن البسودوبودز يلي موجودين بالاوستيوكلاست على الطابق فوقاني. هيدي كيف ترجعي تحرق دينا على الطابق فوقاني. You see these resorb bone. They resorb bone through Hoship's lacunae. This does not exist in osteopetrosis. And you see islands or bars of calcified cartilage which has not been eroded or removed within the mature trabeculae. So we have osteoclasts without ruffled borders, yani pseudopods that resorb bone. If you catch them, you can probably do a bone marrow transplantation for the infants. There have been successful cases, and you can give interferon gamma 16 for the delayed type. Now, what we've been observing is that there are certain cancers, مثل breast cancer, lung cancer, they have an associated osteomalacia. And this is tumor-induced osteomalacia. What is the definition? Paraneoplastic syndrome of the renal phosphate wasting caused by a bone tumor or soft tissue tumor that secretes a substance that leads to osteomalacia. And this is a question for the written. The putative factor is phosphotonin. A possible gene is the fibroblast growth factor 23. Often a long delay in detecting the tumor. We don't detect, there are certain tumors that go on and we don't detect them until late. These patients develop a paraneoplastic syndrome. The etiology, there are 4 types of tumors that cause oncologic osteomalacia. We have a phosphaturic mesenchymal tumor, mixed connective tissue. We have an osteoblastoma-like tumors. We have ossifying fibrous tumors. We have non-ossifying fibrous tumors. These produce phosphatonin, which act and allow excessive phosphate loss through the urine. As a result, they develop osteomalacia. What do these patients have? They have progressive bone and muscle pain. They have weakness and fatigue, and they have fractures of long bones, ribs, and vertebrae. The imaging appearance is diffuse osteopenia, pseudofractures, which occurs typically in osteomalacia. And you can detect the tumors by octreotide scan, indium-111 plus pentitriotide, scintigraphy, radio-labeled somatostatin analog. هلا أحملكم شيء. هلا أسامي كتير فلسفة. But if you answer by a simple indium scan or any scan, it's detected, it helps in the diagnosis. If you mention this in an exam and you can localize the tumor, this is your answer. What are the laboratory features? طبعا عم نخسر phosphate بالurine from the proximal convoluted tubule and the distal tubule. We lose a lot of phosphate. We have phosphaturia due to the low proximal tubular reabsorption in the proximal convoluted tubules. You have a low serum 125 dihydroxy vitamin D. And the treatment is removal of the tumor, of course, and phosphate supplementation with 125 dihydroxy vitamin D. Hypercalcemia and malignancy. Hypercalcemia may develop in patients with cancer. Two types, with diffuse lytic metastasis, 20%, and without 80%. Hypercalcemia with diffuse lytic metastasis is commonly associated with the following types of cancers: breast cancer, hematologic malignancies such as multiple myeloma, lymphoma, and leukemia. Hypercalcemia without diffuse lytic metastasis is commonly associated with the following types of cancers: squamous cell carcinoma, you have hypercalcemia. Renal or bladder carcinoma, you have hypercalcemia. Ovarian or endometrial cancer, hypercalcemia. Breast cancer. So when you have these cancer cases and you have a high blood calcium, think of these tumors, think of them. They are associated with hypercalcemia. There are lesions which are associated with loss of phosphate. You have to see, you have to know. The etiology is local or circulating factor that causes bone resorption and release of calcium ions. What are the clinical presentations? Neurologic-wise, they have difficulty in concentrating whenever they have a high level of calcium. They cannot sleep well at night. They have depression, confusion, and coma. This is a sign of hypercalcemia. You have to know the basic findings of hypercalcemia. Gastrointestinal, they have constipation, anorexia, nausea, and vomiting. Genitourinary, they have polyuria and dehydration. And in cardiac, they have shortening of the QT interval, bradycardia, and first-degree block. يا شباب اذا بتشوفوا هون اللي عم بعطيكم اياهم، هون ما بتقشعون بالاورثوبيدكس. انا بشارك تكون عم تسالوا ليش عم بيعطينا هو. These are the basics of orthopedics. Anybody who knows about trauma that does not know about these is not an orthopedic surgeon. Believe me, you can arrive at a diagnosis by just knowing these. The radiographic appearance is diffuse lytic metastasis, may or may not be present. The laboratory features hypercalcemia, normal or high serum phosphorus levels, low parathyroid hormone level. And you see that is in osteoclastic bone resorption on pathologic slides. The treatment is when we have something eating up bone. What do you give? You give biphosphonates. This holds the osteoclastic bone resorption. Why? Because the biphosphonate surrounds the hydroxyapatite crystal and prevents the osteoclast from resorbing it. And you need a combination therapy of chemotherapy and radiation to kill the cancer cells. Paget's disease. Remodeling disease characterized initially by osteoclast-mediated bone resorption and then disordered bone formation. One of the questions I love to ask in the exam, and I'll be honest, I don't know when it's coming, if it came or not. What is the first stage of Paget's disease? It's usually a lytic process. It's secondary to osteoclastic-mediated bone resorption. And this condition is common in patients older than 50 years. The etiology, some say it's secondary to a virus, and usually they condemn the paramyxovirus respiratory syncytial virus. We don't see this very often in our sector. We see it mainly in Caucasians of Anglo-Saxon descent. And believe me, it's very common. It has a strong genetic tendency, and it is autosomal dominant. Now, we have special genes. One of the genes that they condemn is the ubiquitin binding protein sequestrosome 1. Okay? What is the presentation? A question I love to ask is, true or false? It's more common in males, it's more common in females, there is no sex predilection. So you have to know that Paget's disease attacks males and females equally. It's generally found in patients older than 50 years, and we have to know that Paget's disease could be monostotic, meaning involving one bone, like the tibia, the femur. I've seen it in metacarpal bones. I've seen it in phalanges. You have to keep this in mind. And when it occurs in the spine, I have seen it. And what does it cause? When you have a large amount of bone formed during the osteoblastic phase, they will have spinal stenosis. And in the vertebra, it can cause a condition which we call the ivory vertebra. It can occur in lymphoma, the ivory vertebra. So you have to think, if I ask a question in the exam, what condition or conditions produce an ivory vertebra, it means that it's an osteoblastic vertebra. It is larger than other vertebrae, and it can cause localized stenosis, because like it grows outside, it grows inside. The common sites are the femur, the pelvis, the tibia, the skull, the spine. And often it can be asymptomatic and found incidentally on a bone scan, chest radiograph, or in patients with elevated alkaline phosphatase, meaning that it's during the osteoblastic phase. Alkaline phosphatase is being formed by the osteoblast. It progresses through 3 phases. And I want to tell you, some say that Paget's disease is just like osteopetrosis in the young. But this is not true. But the thickening of bone, if they tell you which conditions produces thickening of bone and anemia, which is produced by osteopetrosis, but not by Paget's disease. There is, during the lytic phase, you have, which is not like osteopetrosis. Why? Because you have a profound resorption of bone. It's a purely lucent on radiographs with expansion and thinned but intact cortices. The mixed phase, you have a combination of lysis and bone formation with coarsened trabeculae. It is the sclerotic phase, which radiologically in the adult could be like osteopetrosis, but each one is very different. One is associated with anemia, but on the whole, Paget's disease is one of the conditions where you have excessive blood supply. You have a difference between systolic and diastolic pressure, which could be quite high, and therefore they have excessive blood. Now, another point you have to know that we have the same problem as we have in osteopetrosis. If you look at the bottom right-hand slide, you see the X-ray of the femur, a transverse fracture of the proximal end of the femur. Now, it's a transverse fracture. These patients have a disturbance in remodeling, and when you have solid bone, biomechanically is weaker than cavity-formed bone. So you have to keep this in mind. They have bone pain, which may be present. And as I mentioned, the bone pain is associated with the increased vascularity and warmth, and they have stress fractures. إذا بتطلعوا بالسلايد على التibia, you see that there's anterior bowing of the femur and tibia. And in the femur, fractures most commonly occur in the femoral neck, and it is well known that patients with Paget's disease have arthritis of the hip and knee. And I would like to tell Dr. Khalid, who told me he had the total hip, that I've had a few cases with Paget's disease that I had to do a total hip on them. And believe me, it was hell to do the total hip. The bone is difficult to ream, especially the shaft of the femur. And don't forget that these patients have lumbar spinal stenosis. Now, what do we know? We know that osteosarcoma occurs, is biphasic, that ما عم تسمع. جاني مسج من عبد السلام that he has an internet problem. عم تسمعوني خالد هون؟ خالد عم تسمعوني؟ حلوا له المشكلة يا عبد السلام، كتب لي إنه عنده problem. No. Am I clear so far?
Yeah, clear.
Yeah. Okay. So we said that there, osteosarcoma is high to occur in adolescents, young adults, and high after the age of 50. When it occurs after the age of 50, it's usually secondary to Paget's disease. Okay, you have to pay attention that, and this is common to occur in the pelvis, femur, and humerus. Patients often note a marked increase in pain, and the pain is usually constant. What are the laboratory features? They have an increased alkaline phosphatase, especially during the osteoblastic phase. They have increased urinary markers of bone turnover, like preadenoline. Why? Because we're breaking down bone during the lytic phase. We have collagen cross-links. We have N-telopeptide hydroxyproxylene and deoxypreadenoline. These are present in excess, especially in the urine, and we could have normal calcium levels. The radiographic appearance, the plain radiographs, they have cortin trabeculae, they have cortical thickening, lucent advanced edge blade of grass or flame-shaped inactive disease. They have loss of distinction between the cortices and the medullary cavity. They have enlargement of the bone. They have a technetium 99 bone scan, which is an increased uptake. They have intense activity, which often outlines the shape of the bone during the active phase. And they have mild to moderate sclerotic phase. CT scans, they have cortical thickening. ليك خالد رجعت لي هالسوداء يلي من فوق، شلتوا لي اياها بالاول من فوق كم واحد موجود هيدا، ما بعرف ليه رجعت لي. انا عم تخطي لي السلايد. So with CT scans, you have cortical thickening, coarsen trabeculae. Pathology includes profound osteoclastic bone resorption during the lytic phase, abnormal bone formation in an irregular way, and this is what we call the mosaic pattern. We have woven bone and irregular sections of thickened trabeculae bone and numerous cement lines. So to recapitulate, you have osteopetrosis, you have tumors that produce excessive amount of calcium, hypercalcemia, and you have Paget's disease, which has three phases. One, the lytic phase, then you have the mixed phase of lysis and bone formation, and then you have the quiescent phase, where you have bone formation in excessive amounts and thickening of bone. If they ask you about the pathology, you say that it's totally irregular. There are many cement lines, and it's what we call a mosaic pattern. On slides, a mosaic pattern. Treatment. Therapy is aimed to stop the osteoclast from resorbing bone and halt the phagetic bone and changes. What we use biphosphonates, and we use oral agents like alendronate and residronate, and we can give intravenous agents like pamidronate and solidronic acid, and calcitonin is used. The salmon calcitonin is administered subcutaneously or intravascularly. Last of these groups, before we go into the inflammatory conditions, is osteonecrosis. Definition: death of bone cells and bone marrow secondary to loss of blood supply. There are several causes to the etiology. There are many theories, because really we don't know the exact definition of the cause, but we know in general it's due to a decreased blood supply. There are four mechanisms. One is mechanical disruption of the blood vessels secondary to trauma such as hip dislocation. الكيس يلي الدكتور خالد عمل اليوم to transcervical fracture of the hip, and it was displaced in an elderly patient, and therefore the high risk of osteonecrosis promoted the use of a total hip. You can also have arterial vessel occlusion. كلنا بنعرف الغطاسين يلي بيغطسوا تحت المي بيعملوا شو بسموها nitrogen bubbles. They cause bubbles, and it's what we call Caisson's disease, sickle cell disease, where they have clumping of the red blood cells, and you can have fat emboli. Injury or pressure on the blood vessel wall is another cause. كلنا بنعرف بGaucher's disease, they have a cerebrocyte which accumulates in bone, and this gives a lot of pressure on the vessel walls and obstructs circulation. Vasculitis. كلنا بنعرف following radiation therapy secondary to sclerosis of the vessel walls. If you have a venous outflow obstruction, and for this reason we call it the compartment syndrome of the hip, can cause it. Hypercoagulable states like decreased anticoagulants. In children, we say that there's a deficiency of protein C and F, and increased procoagulants. The clinical manifestations, the patient may present with a dull pain in the joint, severe arthritic pain with collapse of the joint, or maybe asymptomatic. The imaging appearance. Initially, the patient comes to you with pain. تعمل له صورة, you cannot see anything. You say, this is a normal hip, especially on comparing the hip to the other side. We know that it's quite common to occur bilaterally. At least 50% or more occur bilaterally. On the other hand, later on, if the patient comes and presents to you later on, you can see sclerosis and cystic formation. And there are special classifications. We will go more into detail later on. There's the FECAT and the Schneider classification. One is an MRI classification. The Hungerford and FECAT classification is not without MRI. Later on, they added MRI. Arthritic changes they have secondary to irregularity of the hip joint. They develop osteophytes, loss of joint space. MRI, they have a characteristic marrow changes in the metaphyseal marrow and subchondral location. Let us see. The pathology is in osteocyte death. The osteocytes are empty. The nuclei don't exist. And there are no cells in the lacunae, the empty spaces in bone. This is a sign of marrow necrosis and cell death. And they have loss of vascular supply of bone. The slides I have on pathology are what we see, okay? Now, if you look at the X-ray of the hip above, on the left-hand side, you see that there is only an increased density in the region of the sorsal of the hip. For several months following it, the patient went into collapse. Yani he has passed the third phase of the FECAT classification, and the head, the necrotic bone has collapsed. Why? The reason why is that when you have dead bone, there is no remodeling. Why? Because the hip is under stress during weight bearing, and it continuously destroys bone and forms bone according to the area of stress. When you have osteonecrosis, this does not exist. And so with time, it fractures. One of the questions I love to ask in the oral exam, why is it that the zone of osteonecrosis is more dense than the other zones? The reason is there is no circulation to remove the calcium. Secondary to pain, the other zones remove calcium. They are osteoporotic, while in the zone of necrosis, calcium is imprisoned. It cannot be removed or added. Now, if you are in the first phase, as is shown in the X-ray on the left-hand side, you can do a core decompression of the joint surfaces. What we mean by core decompression? Core decompression is when we drill from the lateral aspect of the proximal femur into the head, directly into the zone of necrosis. This should be done during the early phase before the collapse. We correct the area, and then we can pack it with bone. I'll tell you, there is a group in the United States that use a vascularized fibula, and they reimplant it through that drill. And it has been tried, but it's not successful by many. Now, in the older patient, when you have collapse, as in the upper slide on the right-hand side, or in the lower slide in C, you will do a total hip replacement. In the elderly, in the young, you try and do other procedures. You can take X-rays in various directions and see the area where the head is most normal, and the zone of necrosis is out of the way of weight bearing. And then you perform your osteotomy accordingly. So these are, when you ask for X-rays, we'll be talking about this in much more detail. You need to take X-rays in adduction, in abduction, in external rotation, in internal rotation, and then you decide where you're going to do the osteotomy, how you're going to do, what is the direction of your osteotomy. But this should be done before the collapse. If you get a late case, you have no choice. You will end up doing a total hip if the patient is older than a certain age. Like you can, nowadays, we're doing it as early as 50 years. This is a zone of necrosis in bone, and you can confuse this with certain tumors like chondrosarcomas or even chondromas, and you have to be aware of it. Now we come to the other section. Now, Khalid, I would like to ask, are there any questions? Khalid, any questions? Hey, any questions? No?
No.
Okay, I'll carry on. Okay. I will be discussing first rheumatoid arthritis, and then we'll take a break to discuss the others. Arthritis, in its different forms, affects almost 50 million people in the United States. So you have to see how common it is. And it is a significant worldwide public health concern. The arthritides include both inflammatory and non-inflammatory conditions, which can be acute or chronic. Osteoarthritis, I don't consider it an inflammatory condition, is the most prevalent form of chronic joint disease. The complex interplay between the joint structures, which include articular cartilage, underlying bone, and surrounding soft tissues, creates a dynamic environment responsible for normal joint movement. Arthritis causes disturbances in these structures and can lead to substantial pain. I'm sure each of you orthopedic surgeons have an aunt or a mother who's complaining of arthritic pain. They have loss of function and eventual decline in overall quality of life. Arthritis and other cartilage disorders can lead to progressive joint destruction or occur as an isolated events with sustained disease remission. It is imperative for orthopedic surgeons to recognize the diagnosis and evidence-based treatment strategies related to the management of arthritis. The arthritides have been the most prevalent cause of disability in the United States for the past 15 years and affect widely ranging population. It was estimated that in more than 52.5 million US adults, some form of arthritis has been diagnosed, and that the symptoms have caused work limitations in 1/3 of those aged 13 to 65. The US Centers of Disease Control and Preventive estimate is that an arthritic condition will be diagnosed in more than 78 million US adults by 2040. هلا يا شباب أوقات نيجي بنقول نتسير بين بعض بنقول rheumatologist. We do rheumatology. I don't think they're totally wrong in the management of arthritic problems because they have a high load of cases in the world, and therefore it's an efficient subspecialty or specialty. So it's used to describe a variety of conditions. The two general conditions are non-inflammatory and inflammatory arthritis. We spoke about osteoarthritis. Now we're coming to rheumatoid arthritis. It is the characteristic inflammatory disorder. Inflammatory arthritis represents an autoimmune state that results in a chronic, insidious, progressive of joint inflammation and destruction. Articular cartilage plays an extremely important role in the functional dynamics of normal joint movement. It is durable, but extremely flexible nature creates a low friction environment in which the bones can glide smoothly without opposition. If we have no cartilage, then it becomes rough and it starts to degenerate. We have many cases which started as rheumatoid and with time, secondary to the irregularity of the joint, shift to osteoarthritis. However, progressive damage from normal wear, injury, or inflammation can disturb the articular environment and cause pain, and they have decreased structural integrity and functional limitations. It is imperative for the orthopedic surgeons to understand the diagnosis and treatments related to arthritis and other cartilage disorders. This is very important. أنا بتعجب when you get trauma surgeons, what would they do if they have a case of rheumatoid arthritis? They should know the basic knowledge about rheumatology to be able to treat these cases. Several forms of arthritis are associated with inflammation of the joint, each of which is characterized by specific symptoms, physical findings, laboratory values, and other systemic manifestations. The affected joints, the presence of symmetric joint involvement, and other clinical manifestations provide clues to the underlying condition. Comprehensive care requires an understanding of the underlying pathology and associated conditions. Orthopedic surgeons are involved in the treatment of joint pain. You have to know what to give. You have to know what are the disease-modifying arthritic drugs and sequelae of each of these diseases. Rheumatoid arthritis is the most common type of inflammatory arthritis. Other types include the seronegative spondyloarthropathies. Seronegative spondyloarthropathies, rheumatoid arthritis. Many of your patients come to you with back pain, have one of these. You can miss them and you say that this is a disc, and then we operate on the disc. And then later on, we see that they had an inflammatory process going on. One of these is ankylosing spondylitis, which occurs in the younger age group. Reactive arthritis occurs at the middle age group. Psoriatic arthritis can occur anytime. And enteropathic arthritis. And the crystal deposition diseases such as gout and pseudo-gout. You have to know these. If you don't know these, you don't know orthopedics, my friends. rheumatoid arthritis. If you look at this hand, you see this is a patient. Oh, this patient has rheumatoid arthritis. Why did she arrive at this stage? It's wrong. We didn't have the proper drugs at past. Nowadays, we can hold, we can prolong the remission in these cases. And they have these patients, once they've reached this stage, you see they have the ulnar drift deformity. Why? Because the extensor tendons have a tendency to pull the fingers in the ulnar direction. There's softening of the ligaments. The joints are dislocated. They can either develop a swan neck deformity or a boutonniere deformity, which I will be discussing. This is another case. Look at the house a bit. It is strictly impossible to try, strictly unforgivable to let them arrive at this stage. We don't want them to arrive. We fight it. We give them special drugs. And we should know how to control these drugs. In my opinion, it is the orthopedic surgeon who should at least treat them at the beginning. Many of you refer these patients to rheumatologists. You're losing, fellows, a good portion of your specialization. We expect you in the board exam to know these things. What is the definition? Systemic inflammatory disease of the synovium is what I want you to say. It's twice as common in females compared with males. According to the American College of Rheumatology, revised criteria, the patient must have 4 of 7 symptoms and have had symptoms 1 through 4 for at least 6 weeks. A bit about genetics. Genetic marker human leukocyte antigen. It's present. You should do an HLA-DR4 on these patients and see if they have it. It's quite common to occur in Northern European descent, patients of Northern European descent. Monozygote twins have a concordance rate of 12 to 15%. These are the criteria to make the diagnosis clinical criteria. يا جماعة ليه رجعتوا لي هالأسود على السلايد؟ ما بعرف. Okay. These patients have morning stiffness, they have arthritis of 3 or more joints, they have hand arthritis, symmetric arthritis, they have rheumatoid nodules in the extensor surfaces, they have a positive serum rheumatoid factor, and radiographic changes. We will see these. Rheumatoid arthritis is a chronic, progressive, polyarticular inflammation of unknown origin. That's why we say it's autoimmune. We don't know much about it. With autoimmune pathomechanism, and this causes destruction of the joints and severe disability, and often is accompanied by extra-articular changes. Serological signs are the presence of rheumatoid factor and anti-filaggrin positivity. This chronic systemic inflammatory disease is characterized by the infiltration of synovial joints by inflammatory cells. It's easy, inflammatory cells, macrophages, and the progressive erosion of cartilage and bone. This is what we call the pannus. The pannus is an inflammatory and cytokines, which surround the cartilage from both sides and infiltrate it, and they destroy the cartilage. This is manifested as a peripheral polyarthropathy and synovial hypertrophy with formation of granulation tissue and pannus on the articular cartilage. The reported annual incidence of rheumatoid arthritis is 40 per 100,000 individuals, and its prevalence is approximately 1% of the US population, and the estimates range from 0.1 to 5%. Rheumatoid arthritis most often is diagnosed in women at the age of 30 to 50. Individuals with human leukocyte antigen HLA-DR4 serotype are most often affected. So you have to ask for this. The risk for disease is increased twofold to threefold in first-degree relatives. Pay attention. If you want to marry a woman who has rheumatoid arthritis in the family, you have to think of the possibility of having children having rheumatoid arthritis. Think of it twice, just like diabetes. All those studies of monozygote twins found only 15 to 20%. Yani 15 to 20% of monozygote twins had rheumatoid arthritis in both the twins. Rheumatoid arthritis initially affects the proximal interphalangeal joint and metacarpophalangeal joint, اللي فرجيتكم إياها at the beginning of my slides on rheumatoid arthritis. The resulting symmetric polyarthropathy can insidiously progress and involve the ankles, the knees, the shoulders, the hips, elbows, and even the upper portion of the spine, the cervical spine, the atlantoaxial joint. You see that there's a pannus seen between the odontoid and the anterior arch of the atlas. And this pushes the whole spine posteriorly, and you'll have limitation of space in the posterior region. And this could press on the cord. Oh, see the amount of pain these patients have. I've experienced so many patients having this. And we have to go in and remove bone from the posterior aspect of the foramen magnum so as to create a space for the cord so that the patient was relieved of pain. And then we did a skull to C2 arthrodesis. So you have to think of these points. Although the exact etiology of rheumatoid arthritis is not understood, progression of the disease is known to involve a complex interplay among factors such as a genetic predisposition, which we've mentioned, environment triggers, and immune regularity modulators. It is widely believed that an external trigger, such as cigarette smoking, infection, or trauma can lead to autoimmune reaction and the subsequent development of rheumatoid arthritis. The characteristic rheumatoid arthritic joint pathology involves a hyperplastic. It's a sketch. You see that there's a hyperplastic synovium which goes in and begins to invade. And this is composed of fibroblasts like synoviocytes. These cells lose cell inhibition characteristics and express extremely high levels of inflammatory chemokines, namely interleukin-1, interleukin-6, interleukin-17, and tumor necrosis factor, and adhesion molecules and matrix metalloproteinases. All these destroy the joint. They surround the cartilage in pannus from both sides, and they destroy the cartilage of the joint. Synoviocytes may be directly responsible for creating the foundation for local cartilage destruction. As synovium becomes hyperplastic, it loses its intrinsic protective qualities and makes the joint more vulnerable to invasion by degrading molecules, such as the matrix metalloproteins, the leukocytes, the macrophages. All these act and destroy the joint. They destroy the cartilage. These enzymes promote the disassembly of type 2 cartilage matrix. Under normal conditions, chondrocytes have a limited regenerative capacity. In rheumatoid, chondrocytes undergo apoptosis because of the presence of the inflammatory cytokines, and the regenerative capacity of the articular cartilage is further decreased. The damage progresses to bone, ultimately resulting in erosion and degeneration. And then now it's shifting from arthritis to to osteoarthritis. The macrophage colony, stimulating factor and receptor activator of nuclear factor XB ligand, may be responsible for promoting osteoclast differentiation, which increases bone destruction. Patients with rheumatoid arthritis may report malaise, weight loss, decreased mobility, morning stiffness with pain. Joint pain may be present early in the disease course with only subtle effusions or tenosynovitis. In advanced disease, the patient may have joint swelling, ulnar deviation, as I showed you at the beginning of the fingers, metacarpophalangeal hypertrophy, swan neck deformities, which I'll show you each of them, boutonniere deformities of the proximal interphalangeal joint, and subcutaneous nodules, especially on the extensor aspect of the interphalangeal joints and the elbow. And signs of pleuritis and pericarditis. Now we come to the interesting part. If you look at this hand, in the exam, we bring a patient and we hold his hand like this. And we say, describe the deformities. If you look at the left hand photo, you see that the patient has a swan neck deformity, which is flexion of the MP joint, extension of the PIP joint, and flexion of the DIP joint. And this happens as a result of softening of the collateral ligaments of the PIP joint, resulting in laxity and displacement posteriorly. On the other hand, you can have a rupture of the central slip and the lateral bands slip anteriorly, and it will give you a boutonniere deformity as is shown in the right hand X-ray, a photograph. Rheumatoid arthritis is associated with an immunoglobulin M or protein M autoantibody against the fragment crystallizable portion of the immunoglobulin and is not specific for disease, but is positive in approximately 75% of patients. So it is the rheumatoid factor. We ask for certain tests like ANA, rheumatoid factor in these patients, but it's not specific for it. What we see is the clinical picture and how it presents together with the rheumatoid factor, together with a sedimentation rate, a C-reactive protein. All these favor the diagnosis with the clinical manifestations. Symmetric joint space narrowing, loss of cartilage, and osteopenia may be seen on radiographic images. In recent years, the management of rheumatoid arthritis has greatly advanced. The current emphasis is on reaching radiographic stabilization and clinical disease remission. This is what I was speaking about at the beginning. We can control it most of the times. There is increasing evidence that suggests that the use of disease-modifying anti-rheumatic drugs offers an early opportunity for optimal treatment benefit. So, fellas, you can detect these patients if you know the knowledge that I just gave you. What you should do is, believe me, you can control the management. Many of the orthopedic surgeons refer them to the rheumatologist. I treat them all, and I follow them up, and I decide when I need to do surgery to correct resultant deformity. Basic knowledge is your best companion, not your enemy. A recent systematic review of the value of early treatment of rheumatoid arthritis and its associated outcomes found that initiation of treatment within 12 weeks of disease onset led to substantially improved, sustained long-term outcomes. If you know the knowledge I'm trying to give you, and you detect it before 12 weeks of onset, and you treat these patients, you're giving this patient a good time of relief. Relatively early achievement of disease remission was found to be strongly associated with sustained and controlled rheumatoid arthritis remission and ultimately led to substantial functional improvement. Factors including female sex, lack of early disease-modified anti-rheumatic drug therapy, and severe pain were associated with lower rates of rheumatoid remission. Therefore, early treatment with disease-modifying anti-rheumatic drugs and rapidly acting anti-inflammatory medications, such as non-steroidal anti-inflammatory drugs and glucocorticoids, has become the standard of care for rheumatoid arthritis. The biologic disease-modifying anti-rheumatic drugs include anti-cytokine drugs such as the tumor necrosis factor inhibitors, etanercept, infliximide, adalimumab, and golimumab. If the patient, I'll tell you, these are difficult to remember. I'll tell you what I have done. I have put a list of these drugs on my computer, and I even printed it, and with the dose and how to give it, and what lab studies should I ask before, because these drugs have side effects. You have to know what are the side effects. Each month or 2 months, you should do a blood test when you're giving these drugs to see the effect on the liver, on the kidneys, etc. So you have to know the knowledge, but it doesn't take much time. It takes a few hours to remember these. If the patient is a candidate for surgery, biologic disease-modifying anti-rheumatic drugs should be وسهل. بيسألوني كتير طيب I'm not disease-modifying anti-rheumatic drugs, but he needs surgery. What should we do? We should withhold it to reduce the risk of surgical infection. However, recommendations as to the length of time these medications must be withheld vary widely. I usually hold them until the wound heals. Yani, I usually wait 2 weeks and then I restart them. The clinical course of rheumatoid arthritis generally is characterized by a periodic flare of up episodes with intervals of remission, and with the advent of new therapies, rheumatoid arthritis outcomes have improved tremendously, and the percentage of patients receiving arthroplasty has decreased. These are clinical cases I'll show you. The incidence of rheumatoid arthritis, 1% of the adult population. Don't forget it's common to occur between 35 and 55 years. HLA-DR4 tissue antigen is detectable at 50% of the patients. Extrinsic factors are also needed apart from the genetical issues for the development of disease. First of all, look at the hand. To diagnose rheumatoid arthritis, you have to look at the following. Morning stiffness, that's number one. Arthritis minimally of the joints lasting for more than 6 weeks. Arthritis of the hand joints lasting for more than 6 weeks. You have to think of a symmetrical arthritis lasting for 6 weeks. If you look at the hands in the uppermost photograph on the left, you see that there are nodules on the extensor aspect of the finger, and you see that there are nodules in the elbow. So if you see a rheumatoid nodule, you have to think of it. You have to do a rheumatoid factor. If it's elevated, think of it definitely. Radiologic changes, you see marginal erosions and diffuse osteoporosis. Rheumatoid arthritis is considered confirmed if at least 4 criteria are fulfilled. So it's not difficult to make the diagnosis. Progress of the disease is characterized by Steinbroker's functional and anatomical stages. Anatomical stages are early, moderately, severe, end stage. Various stages can be present, but I tell you, if you diagnose rheumatoid arthritis, you can diagnose it at any stage if you know what I just gave you during this hour. Let's look at cases. This is an early case of rheumatoid arthritis in a female patient. You see that is typical, symmetric hand and feet deformities. And they have bilateral, mild knee swelling. طلعوا بالfoot, طلعوا بالhand. Just look at it. It's not difficult to diagnose. ما تجوا تقولوا لي اجتنا case of hallux valgus. My friend, look at the other toes. See if they're dislocated. You have to know these because the operation is completely different in these cases. The patient should not reach at this stage. Suspect for early rheumatoid arthritis if you have fusiform swelling on the fingers. The radiograph shows stripped periarticular atrophy of the phalanges. So keep this in mind, okay? Keep this in mind. You have to really have this in your mind as you're looking at these patients. This is another patient of a severe case of rheumatoid arthritis. This patient has been suffering from rheumatoid arthritis for 20 years. She's a chronic case. Note the altered face. Secondary to what? Secondary to steroid treatment. That's how she has redness of her cheeks. She has an altered face. طلعوا بالhands. طلعوا بالإجرين يا جماعة. So don't forget these. If you look at the hands, you have to know that there's atrophy of the intrinsic muscles. You see that there's inflammation of the fingers, of the interphalangeal joints, the metacarpophalangeal joints. So don't forget these. Look at the intrinsic in the lower photograph. In B, that I have mentioned, you see that there is definite atrophy. And you see that the carpets are being dislocated from the distal radius. This is a patient with a piano key sign. We love to ask this question. إذا بتلاقوا بالروماتويد arthritis بصير عندكم dislocation of the distal end of the ulna. بتقشعوا مثل دنجورة طالعة لبرا. إذا بتحط الإندكس finger at the distal end of the ulna تكبس عليه بتفوت لجوا بعدين بتشيل ايدك تطلع. That's what we call the piano key sign. This is a patient with chronic rheumatoid arthritis who has severe deformity. We have a typical swan neck deformity on the hands. The PIP joints, or the proximal interphalangeal joints, are in extension, which gives you the swan neck. The distal interphalangeal joints are in flexion. On the index finger, you have a typical buttonhole deformity. The PIP joints in flexion and DIP joints in extension. Okay, so you have to know the difference between a boutonniere and I want to show you, I'm trying to see what it is, a boutonniere. At times, you see, this is early before the typical ulnar drift deformity occurs. This is what we call scoliosis of the hand. So keep this in mind in rheumatoid. Now, the X-ray appearance of moderately severe and severe wrist changes. The ulnar epiphysis is destroyed. طلع على الulna. You see it's completely destroyed and subluxed. Okay, and there is a decreased radiocarpal and intercarpal joint spaces. As end result, the wrist is ankylosed, the bones of the carpus are fused, creating a single bone. This is the ulnar drift deformity. They also have a dropped wrist. Why do they have a dropped wrist? That's a question I love to ask. Why do these patients have a drop? Why? Because they have inflammation of the extensor tendons with the pannus, with the synoviocytes that destroy the tendon, and these tendons rupture. One of the first tendons to rupture is the extensor pollicis longus as it passes over Lister's tubercle. Okay? So don't forget this. This shows you the inflammation, the tenosynovitis, the hypertrophic synovial tissue is visible, penetrating into the tendons, the hypertrophic synovial tissue, and its enzymes damage the ligaments and the tendons running in their sheets. This is the mechanism of development of joint deformities, subluxations, and tendon ruptures. Don't say that this is only in the hand. Also, the foot, you have chronic bursitis, you have metatarsophalangeal joint synovitis, you have induced swelling under the dropped metatarsal heads, and they cause severe metatarsalgia. ما تيجي تقولوا لي عنده a forefoot metatarsalgia. No, you have to make sure, does this patient have any inflammatory condition? Yes, Jamea, the treatment is very different when you do these osteotomies, when you do these recession osteotomies of the metatarsal. The treatment is very different. You have to know this. This is a patient. If this patient comes to you, you'd say, oh, yes, a severe form of hallux valgus, and I want to treat it as such. You will do an osteotomy of the first metatarsal, or a chevron, or whatever you want to do, and correct the deformities. This is not so. The patient would continue to complain of pain. Look at the x-ray, look at the joint, look at the destruction of the joint. The treatment is very different. You have to remove the metatarsal heads in these patients. So don't forget about this. Don't forget about this. ما تروحوا تعملوا لي الفانسي osteotomies of the first metatarsal and say, oh, look at how well I obtained the result. You've harmed the patient much more. Look at their toes. You should never forget. Whenever you get these severe deformities, think of an inflammatory process that is happening that caused this. Okay? Please don't forget. They also have nodules at the elbow on the left-hand side in the region of the heel. Also, they can have Achilles problems. Now, what we mean, one of the questions we ask in the exam, if you take a nodule and you take a specimen and you prepare a microscopic slide, you see that microscopic picture of a rheumatoid nodule is of diagnostic value. You see that there is a central zone of necrosis with a peripheral zone of histiocytic palisading. Threshold histiocytes are perpendicular to this zone, and the zone which is central is the central zone of necrosis. The basic disease over here is what? This patient had rheumatoid arthritis and was on steroid treatment, and the patient had osteoporosis and secondary hip protrusio acetabuli. You see, these patients have osteoporosis. They have softening of the bone. and they develop a protrusio. This can be bilateral. We call it an autopelvis in rheumatoid or in the seronegative arthritis. So don't forget this. And in addition, he developed femoral necrosis and was sent to Dr. Khalid to do a total hip. Now, the milkman fracture on the tibia and fibula with valgus deformity of the knee. This is both common in rheumatoid arthritis. The intraoperative picture is extremely hypertrophic synovium, filling up the intercondylar space. The pannus invades the cartilage as is shown over here at the region of the black arrow. The proliferative synovial pannus destroys the cartilage, partly mechanically, partly by its enzymes. The high intra-articular pressure expands the joint capsule, causing pain, joint laxity, and leads to muscle atrophy via reflexes. These are two cases, two showing one pathology, showing of you of how the synovium is invading the cartilage, and it shows you a fracture secondary to insufficiency. What about in the spine? Look over here. You see, this is the pannus. I wish you can see it. I want you to see it in the MRI section over here. You see the whole odontoid is moving posteriorly. And if it reaches less than 40 millimeters, this will cause a zone of stenosis. And this zone of stenosis will lead to cervical myelopathy. Patient will have severe pain. So what we do, look at the pressure from behind. What I do is I remove a portion of the skull from behind to widen the area, and the patient is much better. But this is not sufficient, because if you remove a portion of the foramen magnum alone, you will be unstable. You're not stabilizing the spine. It becomes less stable. And so we have to do a fusion, a posterior fusion from the occiput to C2. I used the Summit instrumentation. It's very good. I concentrate on the center, and I put lateral mass screws in the posterior arches to hold the spine in proper position. So this is a brief resume. Remember morning stiffness. Remember joint swelling. Remember effusions. Remember synovial proliferation. Remember deformities, hand deformities. And remember periarticular osteopenia, juxta-articular erosions, joint space narrow. These we spoke about. This you have to know. And now we come to the second section. Okay, I want the break. I need it. Okay? خالد بدي بريك أنا 5 دقايق 10 تعبت. Was I clear? Was I clear?
Everything is clear.
مبسوطين يا شباب؟
مبسوطين كلهم، وفي أسئلة بعد ما تقبل بريك.
Okay. If giving this lecture and you have a cold, it's bad.
دكتور جون
Okay.
مع الدكتور محمد بيسأل قال الريفرال يعني للروماتويد بيشنت للروماتولوجيست يعني
ما عم بسمع خالد، ما عم بسمع.
دكتور جون اسمعني.
هلا عم بسمعك.
ايوه يعني هو الدكتور محمد واحد من المقيمين السنه 5 بيسال قال الاحاله يعني ريفيرال بيشنت للروماتولوجيست يعني ما نحاول ما نسوي لهم ريفير ونعالجهم احنا.
Let me be
يعني
honest, Khalid. Let me be honest. If you have the proper training, you are conscientious and you know how to follow up your patients. You see these treatments مثل ما هن درسوا وانت درست. إذا بتعرف السايد effect تبع these modifying drugs and you know how to follow up your patients. You see, the problem is not only in the treatment of these conditions medically. The problem is in the proper follow-up. أنا رح بجاوبك شغلة. أنا كان يجيني rheumatology patients وحولن للروماتولوجيست. يمرق سنة سنتين لاقي إنه غير جراح عمل له عمليات and I was asked to solve the complications of the surgery. من بعدها قلت ما بقى أعمل هيك. صرت أنا عالجهم and I follow up my own patients. There are many orthopedic surgeons who are afraid to deal with this. It depends on your training, يا Khalid. Let me be honest.
Actually, Dr. Jone, we face many cases in our clinic.
You say
يعني
حرام not to treat them. عم بتروحهم من ايدك يا خالي.
Yeah, I didn't refer to the rheumatologist. I follow them, and
that's what you should do, Khalid.
Yeah.
Look, I tell the youngsters, فوتوا على حيلا reference وشوفوا شنو الديزيز modifying drugs. إن يمكن شيء 8 يا 10.
يمكن
the side effects. How to give them. What tests you should do on them. It's very important.
This is the truth, Dr. John. But our colleagues are afraid that when they refer to another specialist or not refer, this is the reason. Because the patient is inconvenient. Yes. Dr. John, we refer to rheumatologist.
في حدا اسمه دكتور بانابز. حدا بيعرف مين دكتور بانابز؟ شحط لي على السكرين. ضيق مني لما بقول هيك.
دكتور جون الدكتور عبد الرقيب المرح استشاري ويعني مسؤول الامتحانات معنا عم يسالك يعني. اقول لك يا دكتور جون بالنسبه للريفرنس الايرلي كيس of rheumatoid arthritis or systemic inflammatory disease, such patients, they are not convenient with you, always chronic visitor, and say the same problem are still keeping with pain and restriction of function, as well as the patient needs something to complete his complaint.
يعني in other words, you're saying it's better for the rheumatologist?
Yes, for that we refer some cases with early young with rheumatoid arthritis or ankylosing spondylitis for rheumatologists. Then they return back to us. But after they will convenient with that the disease is well still with life. Because when you visit the patient at first time and you give him medication, he take it for a part of time and stop it. And he return back to you, the pain return again.
So in other words,
with your,
yeah. You have to work together. It's a multidisciplinary situation.
abroad.
But you need a rheumatologist, to be honest. There are many rheumatologists who are not very honest. They take the patient and they refer them to elsewhere, and they don't even take part. This is wrong.
Yes,
so I'll tell you, if you don't want to deal with them, you should choose a rheumatologist who's honest, who would work with you in cooperation. This is a very important point. Yes, you've got an important point.
Thank you دكتور جون.
نبلش؟
نبلش. هذا الشاشة شو بها ما أدري.
لا في عندي بعد كثير أعطيكم.
خذ راحتك دكتور جون.
طيب يلا لا بلش.
بلش.
ليك في واحد شحت لي على السكرين.
ايوه
كيف بدي اشيلها هيدي؟
هذا دكتور صلاح الان will manage this problem.
من هو هذا يا ليش؟
من هو دكتور صلاح؟ من هو هذا؟ ها؟ واحد من الهند الشقيقة يا دكتور.
مين؟ هولي من عندكم او من غير محل؟
من الهند. من الهند. لا من هندي.
من الهند.
برناز. واحد هندي.
طيب يلا ماشي الحال. نقدر يعني صارت السكرين احلى بكثير هلا. عرفت؟ يا ترى اذا ظهرت ورجعت فتت بروح هيدا؟
استمر انت دكتور. هو الدكتور صلاح بيحاول يمسحه. خلاص استمر عادي.
اوكي. هيدا في حدا زعل مني لان قلت لكم انه you should treat the rheumatology cases. I'll tell you, I repeat, if you got full training, if you got rotated on rheumatology clinics for 1 year, you are capable of dealing with these patients. And to this person who scribbled on my slide like this, I think he is ignorant. He should have joined in the discussion and protected his opinion.
Maybe dermatologist. Thank you.
Okay.
Okay. You can start.
Yeah. Typical joint juvenile idiopathic arthritis. This is the rheumatoid process that occurs at the younger age group. And it is most frequently present in a systemic and polyarticular form. In addition, one should not forget the side effects that one gets from steroids in these young individuals. طلع deformities of the patient. طلع الchest تبع patient. These are the cases that occur at a young age, which we will be discussing. Juvenile idiopathic arthritis is the most common chronic rheumatologic disease in children. Juvenile idiopathic arthritis is defined as an autoimmune inflammatory joint disease occurring in children younger than 16 years, and it is characterized by a non-migratory arthropathy affecting one or more joints for longer than 3 months. This illness may start from age of some months to 16 years, and it's most common between 1 and 3 and 8 and 12 years. Girls are more likely to suffer in the first 6 months. Juvenile idiopathic arthritis can be classified to 3 well-defined subtypes. You have the systemic form, which is from 25 to 30%. You have the polyarticular form, which occurs in 30%, and more than 5 joints are involved. And you have the oligoarticular, which is from 40 to 45%, 4 or less joints are involved. Depending on the combination of symptoms, juvenile idiopathic arthritis is classified as oligoarticular, polyarticular, or systemic. The estimated annual incidence of juvenile idiopathic arthritis ranges from 4 to 14 per 100,000 children. Children aged 1 to 3 years or 3 to 10 years are the most commonly affected. The pathogenesis and etiology of juvenile idiopathic arthritis are unclear, although interactions of genetic factors, immune mechanisms, and environmental exposures are believed to contribute. Research suggests that the major histocompatibility complex loci play an important role in the genetic predisposition to juvenile idiopathic arthritis. An infectious etiology has long been suspected. Rubella virus, Epstein-Barr virus, chlamydia, influenza, and parvovirus have been suggested as possible infectious etiologies, but epidemiologic studies have not found a statistically significant correlation. Affected children often have a history of joint arthralgias, morning stiffness, and fever, as well as other symptoms that depend on the type of juvenile idiopathic arthritis. In oligoarticular juvenile idiopathic arthritis, no more than 4 joints are affected, and the peak incidence of this variant is in children 2 to 3 years. The child commonly has swelling and decreased motion in the large joints, with the exception of the hips. Approximately 30% of patients have extra-articular involvement, such as uveitis and iridocyclitis. It is uncommon for oligoarticular juvenile idiopathic arthritis to become chronic, and in most patients, it is resolved within 6 months. So the oligo is more innocent than the others. Polyarticular juvenile idiopathic arthritis has a bimodal peak incidence. It's first between 1 and 3 years, and second between 9 and 14 years. This form of juvenile idiopathic arthritis involves 5 or more joints. The symptoms usually are symmetric and can involve both the spine and hands. Although symptoms are resolved by the age of 15 years in approximately 60% of patients, polyarticular juvenile idiopathic arthritis can also become chronic. So you have to keep this in mind. But in 60%, they resolve and the child no longer has any problem. What about the systemic juvenile idiopathic arthritis? This occurs in children younger than 17 years, peaking between 13 months to 2 years of age. Any number of joints may be involved. Systemic juvenile idiopathic arthritis causes acute flares of severe joint pain and is associated with spiking fevers, neck stiffness, maculopapular rash, and organomegaly, lymphadenopathy, and pericarditis. The prognosis varies widely, although the symptoms eventually are resolved in approximately 50% of the patients. Radiographic imaging is useful for the diagnosis of juvenile idiopathic arthritis and may show osteopenia, subchondral sclerosis around the involved joints. The treatment is multifaceted and varies by subtype, but non-steroidal anti-inflammatory drugs, corticosteroids, and disease-modifying drugs such as methotrexate commonly are used. Biologic disease-modifying anti-rheumatic drugs such as tumor necrosis factor inhibitors are used for the refractory juvenile idiopathic arthritis. In reply to these, in these pediatric cases, it would, of course, to please the one who scribbled the screen, it would be better that a pediatric rheumatologist deal with them because they are more acquainted with the doses at a young age. But in the adults, I still stick to my opinion. Pediatric orthopedic surgeons may be the first providers to identify patients with juvenile idiopathic arthritis. Surgical treatment may be indicated to address deformities. The rheumatologists should be aware of this. I've seen patients having deformities for some time. When I've seen them during the normal phase and the rheumatologist didn't even bother to refer them back for surgery. Limb length inequality or end-stage arthritis. Careful preoperative planning and perioperative management in consultation with a patient's rheumatologist are important for successful surgical outcomes. This is what I stress. We believe in rheumatologists, but the rheumatologist should be aware when he has deformity that other people should deal with his case. Just as he thinks that when we first diagnose a rheumatology case, we should refer them to him. He should think the opposite, when to refer him back. To my unhappy situation, I haven't seen this take place. Juvenile idiopathic arthritis is the most common heterogeneous connective tissue disease of childhood. Don't forget that it leads to severe disability and blindness in a number of cases. Blindness, secondary to the uveitis and the iridocyclitis. Diagnosis can be established if, according to criteria, at least one joint inflammation is present for a minimum of 3 months and other illness causing arthritis. Infection, trauma, hematologic disorders, neoplasia, hemophilia, and psychogenic rheumatism. These are the excluded incidences 1 to 2 per 10,000 children. The characteristic growth disorder is also seen. These children have micrognathia and they have short metacarpals. Look at them. Don't forget this. Often they are hardly visible but palpable in early stage of juvenile idiopathic arthritis. Swelling of the small joints of the hand. Later on, the disease progresses and a mutilating destruction of the small joints of the hand and wrist develops, like in this case of a 22-year-old woman. Juvenile idiopathic arthritis in the early stage. You can see that the X-ray of both knees shows that the joint is intact. Cartilages of children are thicker and more resistant than the adults. Intraoperative picture of the same patient demonstrates obvious synovial proliferation and pannus formation. In early stage, under the pannus, the cartilage could be intact. Late stage, severe knee joint deformity, subluxation, extreme valgus deformity. These are referred back to us at this stage. We prefer that they're not at this stage, that they decide to refer them back to the orthopedic surgeon. These are characteristic features showing a short femoral neck and relatively large, greater and lesser trochanters. The synovitis caused earlier closure of the growing plate of the femoral neck of a 14-year-old female. Other typical changes are the valgus neck and central cranial migration. The extreme small sizes due to growing disturbances and bilateral serous destruction and proximal migration of the femoral heads are characteristic for serious cases. The patient was 17 years old, so you can see what is happening. There's a disturbance in growth. There's a destruction of the joint. There are deformities of bone. All these should be looked aware. In other words, in bone tumor surgery, we've gotten all used to a multidisciplinary approach. We would meet together and discuss the best treatment for the patient on a weekly basis. Over here in rheumatology, both orthopedic and rheumatology specialists should meet together and discuss patients. When should surgery intervene? When should the medication be stopped before surgery? How long should it be stopped? All these should be discussed in a multidisciplinary way. This is the hip and knee ankylosis with severe flexion deformity of the hand. Deformity and skin signs of steroid treatments, striates, are present in a 21-year-old female with juvenile idiopathic arthritis. So pay attention. I repeat, to please whoever scribbled on the screen, if you want to work together, it's got to be a multidisciplinary treatment of these patients in cooperation, and both need surgery and both need medical treatment. This is a slit lamp picture of iridocyclitis, which frequently accompanies juvenile idiopathic arthritis. This is difficult to detect and often ends up in blindness. So in juvenile idiopathic arthritis, beware. These patients should be seen by ophthalmologists on a monthly basis to avoid blindness. Now we come to seronegative spondyloarthropathies. This is where we, spine surgeons and orthopedic surgeons, come in close contact with this condition. The seronegative spondyloarthropathies are a group of inflammatory joint disorders characterized by axial skeletal involvement. They have enthesitis. Enthesitis is an osteophyte or ossification at the ends of tendons. They have an elevated HLA-B27 and a negative result for rheumatoid factor on serum analysis. In other words, rheumatoid factor is negative. These diseases affect the spine, peripheral joints, and other non-articular structures. The seronegative spondyloarthropathies include ankylosing spondylitis, reactive arthritis, psoriasis, and enteropathic arthritis. We'll start with ankylosing spondylitis. Ankylosing spondylitis is the most common seronegative spondyloarthropathies. Throughout my work over several years, I've seen several cases of seronegative spondyloarthropathies, and the far majority were ankylosing spondylitis. The estimated prevalence in the United States is 0.1 to 2% of the population. The disease is most common among men aged 20 to 40 years and people of European descent. Ankylosing spondylitis is characterized by chronic inflammation of the sacroiliac joints and spine, which eventually causes fusion of the vertebral bodies, often seen on radiographs as the so-called bamboo spine. The pathogenesis of the disorder is unclear, but it is believed that HLA-B27 and immune-mediated mechanisms involved in cytokines, tumor necrosis factor, and interleukin-10 are involved. Patients have hip and low back pain that is worse when arising in the morning or after inactivity, but improves throughout the course of the day. In patients with clinical symptoms of ankylosing spondylitis, a radiographic diagnosis can be made using MRI or CT scan. Khalid, I want to ask you, are people bored? Have I taken too much time? Khalid. Khalid.
دكتور جون ايوه
كمل او لا؟
هو كمل اكيد يعني كمل البرنامج كامل المحاضره اللي هي بقيه السلايدات.
I feel that this lecture at this time is much more interesting than the beginning. So I think it's nice that you attended.
Yeah, okay. And all of our colleagues are listening to you, and it is very interesting subject.
حتى يلي شحت على السكرين, is he listening to me?
اللي شحت السكرين والله ما أدري راح. ما بقى. يلا
ذوقه بدل ما يحكي
يمكن بيرجع.
ايه
هو تعرف كيش هو متابع كويس، هذا اسمه اسمه برناف، لكن الآن مش موجود.
مش من اليمن هيدا؟
لا مش من اليمن، لا من الهند.
من برا.
طيب. من برا ايوه.
طيب. Spondyloarthropathies are diagnosed with sacroiliitis. خليني اقول لكم شغله. بيجي لعندي patient بيقول لي فيت لعندك قايلين حكيم عندي ديسك. Of course له حق يحكي عندي ديسك، بس يا ترى did they do a proper examination? Many of the young individuals who come to my clinic complaining of back pain with some radiation to the buttocks and lower extremity have spondyloarthropathies. It is very simple to do several simple examinations, which I will be discussing. Of course, the blood test, you should do an HLA-B27, and you should look for dactylitis, a positive family history, because it's quite common to occur, inflammatory back pain, enthesitis, arthritis, and inflammatory bowel disease or uveitis. A variety of classification criteria exist for seronegative spondyloarthropathies. All criteria incorporate clinical manifestations such as inflammatory back pain, limitation of lumbar or chest expansion. Pay attention. Back pain, limitation of lumbar, Schoberg sign, chest expansion, measure the dimension of the chest. On plain x-rays, do they have enthesitis and the radiologic manifestations? All these we will discuss. The primary treatment of ankylosing spondylitis consists of physical therapy and exercise to prevent delay permanent deformity. Analgesics, non-steroidal anti-inflammatory drugs, and muscle relaxants can be used in conjunction with physical therapy to provide symptomatic relief of muscle spasms and arthritic pain. These medications do not affect disease progression. However, disease-modifying anti-inflammatory drugs also are useful and can be an alternative treatment for patients who have refractory symptoms. Sulfasalazine, this is quite commonly used, methotrexate likewise, and anti-tumor necrosis factor agents, etanercept, infliximab, etc., have been used for treatment, although more research is needed to clarify the role of these drugs in the treatment of ankylosing spondylitis. What is the definition of ankylosing? Inflammatory disorder that affects the spine and sacroiliac joints and large joints, such as the hip in young adults. The male to female is 3-to-1. In the past, we say that this was a disease of the male, but we began to realize that there are females who have ankylosing spondylitis. The etiology, 90% of patients with ankylosing spondylitis have HLA-B27 antigen. It's an autoimmune disorder. You have high levels of tumor necrosis factor, and you see that it's an elevated CD4, CD8 plus T cells. What does the patient present? Now we come to the interesting part. Clinical presentation, they come to you, ouch, my back, I have a disc. Well, that's not. Look at the age of the patient. The age of the patient. Discs usually occur middle-aged and above most commonly, except in young adults when they're doing a very aggressive form of sport, they will have a disc, a rupture of the disc together with the physis. Sorry. They have low back pain and pelvic pain. They again have morning stiffness, hip arthritis in approximately 1/3 of the patients. They also have uveitis, and they have light sensitivity. They can have heart involvement, aortic valve insufficiency, and 3rd-degree heart blocks. The radiographic appearance, the sacroiliac joint inflammation is shown in the upper slide, part of the slide. Blurring of the subchondral margins, erosions, bony bridging, the lumbar spine, they have loss of lumbar lordosis. إذا بتطلعوا بالvertebra بالlow MRI or even in the middle X-ray, you see that they are a rectangle, they are squared. تطلعوا equal anterior and posterior. They are squared of the vertebrae. And you see that there are osteophytes bridging. هلا بيقولوا لي شو الفرق ما بين diffuse idiopathic skeletal hyperostosis and ankylosing spondylitis? The osteophytes in this are usually horizontal, and there is no fusion between the vertebrae. The osteophytes in ankylosing spondylitis is vertical, and they end up by fusing using the anterior longitudinal ligament and posterior longitudinal ligament. It becomes one block. What are the laboratory findings? We spoke about HLA-B27. 90% of the patients, they have an elevated ESR and CRP, inflammation of the ligamentous attachment sites, erosions, subchondral inflammation, and ossification of the joints as the sacroiliac joint, arthritis, they have a pannus formation with lymphoid infiltration. Treatment is anti-tumor necrosis factor therapy, infliximab, etanercept. So these you have to think of. This is the Schober test that we do because they have stiffness, they have squaring of the vertebra, and you measure a certain distance. Would you excuse me just to answer this phone? جورج عندي اجتماع عم بعطي محاضرة جورج. The distance between two marks as the patient spreads, if it increases, it tells you that there's no spasm and the patient has good range of motion. But in these patients who have ankylosing spondylitis, the distance does not spread, it's limited. This is known as the Schober's test. Another point, we look at side bending, how far the patient can side bend. We look at the hand, how far he can tilt. These are to be recorded in your notes. In addition, you want to see how much the patient with ankylosing spondylitis is tilted forward or has a positive sagittal balance. You ask him to work a stand on the wall, and you measure the distance of the occiput from, or the distance of the walls to a fixed point, مثلا the air. You will see whether he's increasing or not at monthly intervals. Also, you should see whether there's any rotation. You put your goniometer at the center of the skull, and you ask him to turn from side to side, and you can measure them. These should be recorded and in your notes. You should expand the chest. We use the nipple line as the mark that we use everywhere. And if we see that there's no expansion, this is, of course, confirming the diagnosis of something occurring in the joints, preventing expansion of the chest. Also, look at the knees, at the concavities on each side. See if there's any arthritis. Look at the heels, see if there's an incisitis or ossification at the insertion of the tendon. This is quite common to occur in these patients. So, the modified New York criteria for ankylosing spondylitis, the clinical criteria, low back pain and stiffness greater than 3 months, which improves with exercise, but is not relieved by rest. This is in vice versa to disc. If you have a disc, when they rest, the pain subsides or decreases. But here it's not relieved because you have a constant inflammatory process. Limitation of motion of the lumbar spine in both sagittal and frontal planes. Limitation of chest expansion relative to normal values. Okay, correlated for age and sex. Radiologic criteria, look at the sacroiliac joints. Look at them, see where is it starting. Usually it starts at the lower end of the sacroiliac joint and moves upward. Why does it start there? Because we have only synovial tissue at the lower end of the sacroiliac joint. And that's very important. Now, you can grade the sacroiliac joint. Normal, grade 1, suspicious changes. Grade 2, minimal abnormality, small localized erosions and sclerosis. 3, unequivocal abnormality of the sacroiliac joints, erosion, sclerosis. And grade 4, finally, they end up with ankylosis. So it starts from the bottom and moves upward. This is grade 0 sacroiliac. You cannot say, is there something wrong with the sacroiliac joints? No, I cannot say. This is a grade 2. Look at the sacroiliac joints. There's some sclerosis on the left side. Grade 3, you see that there is beginning to form erosion, sclerosis, and it started from the bottom and it's moving upward. And this is an MRI showing the inflammation around the sacroiliac joint. Sacroiliitis by MRI on radiographs plus 1 SPA clinical criterion. The clinical criterion is, you have to look at the left, are inflammatory back pain, arthritis. These are all documents to make the diagnosis, okay? So you have to look this up. Now, you see the bridging syndesmophytes. The bridging syndesmophytes are ossification of the anterior longitudinal ligament. You see erosions and sclerosis, and you see these syndesmophytes. Now, over here is what I said. إذا بتطلعوا this patient has a dish. أول شيء بتطلعوا بالvertebral bodies, they're not square. بتطلعوا بالاوsteophytes, gene horizontal. بتطلعوا بالvertebral bodies ما في fusion. This is dish, diffuse idiopathic skeletal hyperostosis. Ankylosing spondylitis, the osteophytes are vertical at the anterior end of the end plates. Never forget this. Never. Also, these patients end up with fusion. These x-rays are at 2 different times, showing you the fusion 2 years following the treatment. The other finding is the Anderson 2 lesion in the ankylosing spondylitis. You can see it. You can see it. This is erosion, destruction of the disc and end plate. This shows you bone marrow edema in sacroiliitis. This shows it to you before the patient is undergoing fusion. This shows you the inflammatory process with sclerosis and erosions. The bamboo spine. Everybody speaks about the bamboo spine. The bamboo is fusion of the vertebra, and it appears like a bamboo. And this is typical of, I would say, seronegative arthritis, mainly ankylosing spondylitis. Ankylosing spondylitis, Marie-Strumfel's disease, Bechtere's disease, pelvospondylitis ossificans. These are all synonyms and is an inflammatory disease of unknown etiology characterized by ascending and progressive inflammation of the spinal joints and adjacent structures with bony fusion of the spine in the end stage. 1/3 of the cases, you have hips and shoulders involved, and they may become involved and less frequently inflammatory lesions of the extra-articular organs, such as the eye, the heart, that occur. So it's not only the hips and shoulders, but the extra-articular, the eye. They can have rhinosinusitis, they can have uveitis in the heart. They can have destruction of the bowels, insufficiency of the bowels. Ankylosing spondylitis is characterized by close association. I repeated this several times. HLA-B27, which is present in 90% of patients. We spoke about this. They have low back pain. Don't forget that you should measure the chest. Don't forget about sacroiliac joints. And you have to be very careful. At the beginning, you might be confused and confuse it with the disc problem. We spoke about the bamboo spine, and this shows you the sacroiliac joints, destruction of the hip joint. This is the final result of how a patient walks forward. We're doing osteotomies to correct the positive sagittal balance. We are successful in doing them. We do most of them in the lumbar area. If it involves the neck, we're doing it at C6, C7 level. Why? Because we don't have a intervertebral foramen for the vertebral artery at the level of C7. So we like to do our osteotomies there and straighten the neck if they have the deformity mainly over there. But if it's in the back, we're doing it in the lumbar area. We're doing either pedicle subtraction osteotomies, Smith-Peterson osteotomies, Ponte osteotomies. We're doing at times VCRs, but these are all associated complications, but we are doing them. We're getting good results. Okay, I've done several cervical spine osteotomies, and really they have been very simply without instrumentation. And we do it under local anesthesia, to be honest. What about psoriatic arthritis? This is quite common. These patients can come to your office presenting with dactylitis. They have swelling of the second toe in a patient with psoriasis. What happens with psoriasis? Psoriasis involves mainly the DIP joint, plus spine, plus other joints. But in the hand, they have a pencil in cup. They have destruction of the DIP joint, and they end up having a pencil in cup. So psoriatic arthritis is a chronic inflammatory arthropathy that occurs in approximately 10 to 30% of patients who have psoriasis. There is a wide variety of clinical manifestations. Most commonly, psoriatic arthritis affects the distal interphalangeal joints and the spine, but it can appear as a dactylitis, incisitis, tenosynovitis, skin, and nail changes in the anterior uveitis. Patients aged 40 to 50 years most often are affected, although individuals of all ages can be affected. The most common clinical features affecting 20 to 50% of patients include spondylitis, dactylitis, inflammatory neck pain, thoracic inflammatory pain, and sacroiliitis. These features may occur individually or in combination and may develop as late as 10 years after the onset of disease. Often, the patient has asymmetric joint stiffness that is worst in the morning and is relieved with activity throughout the day. This pattern is similar to that of joint pain in the rheumatoid arthritis, but the symptoms usually are less severe in psoriatic arthritis. Radiographic imaging in conjunction with clinical history examination can lead to an appropriate diagnosis. Plain radiographs, and you have highly destructive lesions of the interphalangeal joints. You have the pencil and cup deformity and periosteitis, bony ankylosis, paravertebral ossification, etc. I want to go through very quickly because I have to finish this lecture because I feel that people are getting bored. So we have to go through this. It's a shame, but I want to mention that psoriasis, the far common, is the one which occurs after several years of skin psoriasis. But there are a few cases which start before the involvement of the skin. You have to keep this in mind. They end up having pain. They end up having spine problems similar to ankylosing spondylitis, but the deformity does not occur as occurs in ankylosing spondylitis. They can have involvement of the sacroiliac joints, hip, etc. So I want you to realize this. You should look at this. This is the psoriatic lesion. They have deformities. This is the look at the DIP joints or distal interphalangeal joints. They have involvement of these joints, and they can have involvement of the hips. Reactive arthritis was once upon a time called Reiter's disease, which is characterized by a triad. They have uveitis, they have pustules, or what we call Blenner lesions of the sole of the foot, and even the penis. Okay, so these, and we believe that this occurs secondary to an infection, which could be chlamydia or any of these bacteria. Also, they have erosions of the Achilles tendon, plantar fasciitis, they have tendinitis, and they have arthritis, which is not symmetric. This shows you the penis in the upper right-hand side, the foot, the hand, the DIP joints, and the ischiasitis involving the calcaneum. Many of the patients who come to you, you make a diagnosis of Haglund's disease. Well, you should investigate them for psoriasis. Ask the question, because we've noticed that many of the cases that we had to remove bone from the superior aspect of the calcaneum, we found out that they have a history of psoriasis. Also, you can have erosion at the end of the calcaneum, as it's shown in the X-ray below. So keep this in mind. Treatment is indomethacin. Recurrent joint symptoms and tendinitis are common. Reactive arthritis, also known as post-infectious arthritis or Reiter's syndrome, is a sterile inflammation of the joints and the associated soft tissues subsequent to an infection involving the gastrointestinal or genitourinary system. The gastrointestinal pathogens most commonly responsible for its development are Campylobacter, Chlamydia, Trachomatis, and Salmonella. Keep this in mind. Neisseria gonorrhea also has been condemned as one of the causes. So it's an autoimmune inflammatory disease. You have to keep this in mind and belongs to the group of seronegative arthritis. Now, there are other conditions that give us a seronegative arthritis, and you have to think of ulcerative colitis as being one of them, and they have sacroiliac involvement. So you have to, these are belonging to the enteropathic group, and Crohn's disease They involve the sacroiliac joint, and you have to keep this in mind in your history. Now we come to another group. هلا يمكن تقتلوني انا لان زهقتوا انا لا ما تعبت انا بقدر احكي لتاني يوم. Crystal deposition.
احنا مش تعبانين.
كمل. اوكي. في شيء اسئله لهلا؟
والكل مبسوطين.
في اسئله شيء؟ اذا بتلاحظوا اعطيتكم تقريبا كل الروماتولوجي. هلا يمكن يلي عم بيسمعني بيضربني، يمكن اللي عم بيسمعني بشحت لي على السكرين.
لا والله بالعكس مرتاحين وعم يعني وتشكروا منك.
يلا برتاح لي شي دقيقتين. اوكي
دقيقتين.
Yalla, we'll speak about crystal deposition diseases. If you look at whenever you get a patient in your clinic with this inflammation, you have to say this patient most probably has gout. Gout is a metabolic disorder. It's characterized by crystal deposition in joints and soft tissues. Elevation of the uric acid level beyond saturation in the synovial fluid results in the formation and deposition of monosodium urate crystals. However, hyperuricemia does not always lead to crystal precipitation. You have to know this. If you have a high uric acid, doesn't mean that you should have sodium biurate deposition in the skin. There are cases which have high levels and never have this. Early disease appears as an acute and severely painful but self-limiting joint synovitis. Disease progression may lead to deposition of urate crystals in peripheral joints, chronic arthropathy, and uric acid nephrodysplasia. Monosodium urate crystals. If you look in the microscope, this is a question we love to ask. We see that the crystals are birefringent. This tells you this patient has negatively birefringent crystals, and therefore it's most probably monosodium urate crystals. And under polarized microscopy, they appear as needle-shaped intracellular and extracellular crystals. This finding distinguishes gout from crystal deposition diseases. The risk factors of gout include a genetic predisposition, the presence of metabolic syndrome, a diet rich in purines from meat and seafood, excessive alcohol consumption, and chronic renal failure. The prevalence and incidence of gout are highest in economically developed countries than in less developed countries. ليش؟ لأن الأكل بيقدروا ياخدوه، بياكلوا تحميض، بيشربوا alcohol, etc. Okay? Probably because of the higher rates of alcohol consumption, meat consumption, and obesity. Gout can be acute or chronic. There's a slow progression after 10 years of acute flares and can lead to inflammatory and structural changes that eventually create persistent symptoms. 50% of this initiation of gout is in the metatarsophalangeal joint of the big toe. Periarticular surfaces such as bursae and tendons may be involved. Crystal deposition may increase silently over time, although the patient is pain-free. In the photograph below, you see on the left, you see the first metatarsophalangeal joint inflamed. Look at the thumb, you see this disposition or deposition of monourate crystals in the skin. And on the right-hand side, you see complete destruction of the metatarsophalangeal joint. Chronic gout develops after several years of acute gouty arthritis. Approximately 20% of patients have a systemic complication such as uric acid kidney stones leading to interstitial urate nephropathy. The treatment is focused on providing relief from acute attacks and offering symptom remission through maintenance therapy, low dosage colchicine in combination with non-steroidal anti-inflammatory drugs such as indomethacin are commonly used for acute flares, and allopurinol is used for long-term prophylaxis. Pseudogout. Pseudogout is characterized by deposition of calcium pyrophosphate dihydrate crystals in joints and soft tissues. Synovial fluid analysis shows rhomboid-shaped crystals that are weakly birefringent under polarized light. The clinical appearance of pseudogout is similar to that of gout. Symptoms like those of gout include acute inflammation, severe pain, joint erythema, and redness. The disease is idiopathic in most patients, but recent studies suggest the association of advancing age, a history of osteoarthritis, and genetic predisposition to target specific joints, such as the knee. إذا بتطلع بالصورة, you see the hand is swollen, just like you will get with any inflammatory condition. But if you look at the knee, you see that there is a faint zone of ossification which correspond to the menisci, and these are the deposition of calcium pyrophosphate in these. So we have 10 to 15% individuals older than 65 years, and 40% of the individuals older than 30 years are affected by pseudogout. You can see how common it is. And another name for it is chondrocalcinosis, and this is a crystal-induced synovitis. But don't forget that iron deposition, copper deposition, all these, and calcium deposition from hyperparathyroidism, all these enter the differential diagnosis. The knee is most effective, and the treatment is with colchicine, indomethacin. Septic arthritis, I will not go through it because we're going to discuss it in one full session. Don't forget about neuropathic arthritis. Neuropathic arthritis is secondary to diabetes, secondary to congenital insensitivity to pain, or any of these diseases. What happens? They develop a Charcot joint, and this is the X-ray appearance that we give. Okay, so don't forget these points, and I'll tell you, this is quite common. I'm not going to go through this, because it's going to take some time. And really, I am tired. In summary, both osteoarthritis and inflammatory arthritis remain significant public health problems in the United States. It is expected that arthritis will be diagnosed in almost 25% of the US adult population by the year 2030. And it is imperative that orthopedic surgeons fully recognize and understand arthritis management to properly care for patients. Important advancements in medicine have led to a variety of novel and efficacious treatment options, with continued collaboration among medical specialties and increasing translational research efforts. The treatment of arthritis and other cartilage disorders will continue to progress. The inflammatory arthropathies include a wide variety of disorders such as rheumatoid arthritis and the seronegative spondyloarthropathies. These disorders are insidious and cause progressive joint cartilage destruction. Advances in pharmacologic therapies have led to a dramatic attenuation of disease progression. Orthopedic surgeons must understand the mechanisms of these therapies. Thank you. في شيء أسئلة؟
Thank you.
خالد.
دكتور جون.
شو؟
دكتور جون.
نعم.
دكتور جون.
نعم.
يا دكتور جون.
عم بسمع.
Thank you very much for this comprehensive lecture for the systemic diseases. والجماعة كلهم الشباب والاستشاريين والأخصائيين كلهم يتشكروا منك.
تسلم. ما تنسى شو خالد، ما تنسى شو قلت لك.
حاضر أيوه.
لا مش هيدي قول تعرفها انت، بس ما تنسى شو بدي اقول لك، انه انا بكون شو بسموها كبلاء، ما اعرف شو بالعراق. العراق طالبين مني اعطي 7 lectures على السباين، رايح اعطيهم lectures بقى.
يعني بتروح بغداد؟
رايح بغداد وبعدين بيجوا بياخذوني من المطار. هيدي السباين تبع سويسرلاند طلبت مني روح اعطيهم، رايح اعطيهم الاي او سباين. بقى سيدنا انا برجع ب 25 بالليل، بتصائب نهار الجمعه، فاذا نعطيها نهار الجمعه يلي من بعدها برجع بعد لكشة ثاني بعد جمعه. ايه
اوكي بس يعني مثل اللي قبل سويناه،
مثل ما عملنا بايام العيد الاضحى.
ايوه بالضبط.
أوكي.
تمام. شكرا استاذ. شكرا.